Hello, and welcome to our session. Our title is A Prescription for Better Care, Views from People Living with Neurologic Illness. Our speakers are Daniel Baker, Nancy Hardaway, Kirk Hall, Michelle Moon, Charles White, Kelly Weinschreider, and myself, Malenna Sumrall. The practice gaps that we will address are lack of knowledge on the palliative care needs of children living with neurologic illness, lack of clear approaches to supporting equity and diversity in research and care, and lack of framework for person-centered care, including spiritual well-being.
Hi, my name is Daniel and I have Duchenne muscular dystrophy. I live in the UK and I'm the trustees of Pathfinders Neuromuscular Alliance. Today I want to talk briefly about a hospital admission I had in 2017. During the summer of 2017, I had my first unplanned admission to hospital in my adult life. It all started with what I thought was normal stomach bloating one night. As the night went on and the pain became worse, I realised something was very wrong. My mum rang our doctor in the morning and we came straight out for a home visit. Within the hour, I was being rushed to hospital in an ambulance. When I arrived at the hospital, I was taken to A&E. Staff there were very slow to do anything. I was screaming in pain by this point, but I guess as I haven't got a strong voice, they didn't feel I needed attention. After I'd been fully assessed, they asked if someone would be staying with me, as the ward I was going to be admitted to didn't have the experience to deal with my condition. My PA announced she was staying, so I was admitted to a surgical ward. I was attached to various strips, had scans and blood taken, and was then seen by a very worried-looking consultant. He told me my stomach wasn't working. There was inflammation and what looked like a twist in my bowel. It was very likely I had surgery, but that was high risk. If I didn't have the surgery, I'd probably die. I was put on the emergency surgery list and told not to eat or drink. The next week was full of things I never want to experience again. I had arterial blood regularly taken to monitor my oxygen, CO2, and other things. Cannulas attached and removed. Attempts to get an NG tube down my throat. This isn't really easy when you're on a nasal mask for 24-hour ventilation. On my second night in the hospital, my throat started feeling very tight and my tongue didn't fit in my mouth. I instructed my mum, who was also sleeping in my room, to get a nurse. After a while, my throat got worse and I was struggling to breathe. The nurse still hadn't arrived, so my mum went to try again. She eventually came and realised something was very wrong. She pulled the emergency cord and my room filled with doctors and other medics, along with a crash cart. Hydrocortisone and Puriton were administered, and after a while, my sats returned to normal. On another night, my mouth started to bleed, probably from the attempts to put an NG tube down my throat. Again, the nurses didn't want to do anything. After a few hours, I started choking and my pillow was covered in blood. They called for a doctor and put ice on my cheek. Luckily, the blood stopped after this. After a couple of days, I was told I had angular distress caused by perindopril, by heart medication. This was also explained with stomach issues, but I didn't seem to realise that at the time. I'd been taking this medication for many years without any side effects, so it was a bit surprising it would suddenly happen. I've done research since I've been home from hospital and found this is actually quite common. In the end, I've spent 2 weeks in hospital. The first week, everyone was expecting me to die. I even had family visit to say goodbye. I was very lucky. My consultant held off on surgery, and eventually my stomach began moving again. The surgery, I'm certain, did not have gone well. The surgeon himself told me he would promote my suffering if things weren't going well. What's surprising is, during this whole time, my palliative team, who have known me for years, were not contacted by the hospital. Even though they thought I was going to die, my clinical psychologist wasn't contacted either. The people who probably could have made things easier, they are specialists, the rest completely in the dark.
I can still remember this gorgeous day when my husband and I were driving to Boston. His name was Larry Peterson, and we were on our way to meet with a movement disorder specialist to find out about surgery for his essential tremor. We even were going to celebrate with red wine and good Italian food. But after a long examination, the neurologist sat down at her computer looking at his CAT scan, and she said, "You have Parkinson's disease." And we were blindsided. We could barely breathe, as if the air had been sucked right out of the room. And we started to cry. In the distance, I heard her talking. "Stop," I said. "We can't take in what you were saying." She turned from her computer and saw us crying and said, "Well, we can talk about next steps later. Make an appointment for a visit 3 months from now." And she left. She was only seeing a familiar disease. For us, it was a life-changing moment when the path you see before you is no longer, and you have yet to see a new path. In retrospect, I wish she just sat with us, just sat quietly, a witness to what we were experiencing. I wish she'd acknowledged the sacredness of the moment with her presence, becoming part of our team. We adjusted to the diagnosis, as you do, our new future, and went on. I'm Nancy Hardaway, and I'm on the board of INPCS as a former caregiver because I believe passionately in neuropalliative care, having experienced the journey without it. 4 years later, our lives had changed drastically. He'd had to close his business, and we moved to Florida to get away from the cold. He fell often, and I couldn't leave him to travel from my work, which was ironically coaching healthcare leaders. Increasingly complex systems had us swinging between the neurologist and many other specialists and therapists, all in different systems and offices, all disconnected. It was like grabbing rung after rung on a jungle gym. He wasn't getting any symptom relief from his Parkinson's meds, so we found a neurologist with a reputation for difficult cases, hopeful he could prescribe something new. He was intrigued by the diagnostic challenge. Finally, he said, I think you might have ALS. Let's get you scheduled for some tests. He left to make arrangements. But once again, the disease was front and center, not the devastation of another life-changing moment, a threshold to a different future. We went from hoping for another 15 to 20 years to maybe 3 to 5 more years. It wasn't ALS, but it turned out to be multiple system atrophy, and our time was even less. We revised our hope to finding some joy each day, and we did that, but the burden of managing symptoms was just kept increasing. I struggled with the physical and emotional challenges. Though my daughter, an expert in palliative care and hospice research, kept recommending it, I just couldn't find palliative care available for neurological patients in our area. We carried on with visits to the neurologist, gastroenterologist, urologist, pulmonologist, speech pathologist, physical therapist, the hospital emergency room, and calls to the fire department when he fell and I couldn't help him up. Through a Facebook support group, I found ideas for tricky symptom relief from carers around the world. I found a new neurologist who diagnosed multiple system atrophy, rolling his chair almost knee to my husband. We'll be here to help you live the best quality of life for as long as possible. Finally, someone was addressing our humanity. After a lengthy hospital stay, Larry came home with hospice care. We were promised a coordinated team approach in the dying process that we hadn't received in the living process. Rather than swinging precariously from rung to rung on that jungle gym, we would finally have a safety net of care. It did not turn out that way. If he had died within the average 14-day length of stay of that hospice, it wouldn't have mattered that they didn't know neurology, but he kept on living. I had to fight for medications and equipment and services to maintain his quality of life with a disease they just didn't understand. Months later, a life-changing phone call came. He deteriorated dramatically. His weight, his speech, his swallowing, his strength, his breathing, everything. Good news, said the hospice nurse manager. Your husband is well enough, and we're discharging you. In the crazy US system of hospice, Larry's 6 months to die were up. She knew nothing about his disease course. She'd never seen him, nor had the doctor authorizing the decision, but they were the experts. The decision was made based on their recorded data, not my observations. With hospice yanked away, instead of driving to see the ocean or the sunset, we went back to specialists for new prescriptions and medical equipment and services. Instead of the fragile peace we'd made with his impending death, we were thrown back into the world of the living. It was a brutal and costly transition. Within weeks, his primary care physician re-enrolled him in hospice, and a few weeks later, he died at home, alone with me and his son. Larry had a good life. We made the most of every moment and loved till that very last hour. But the emotional and physical demands, the multiple emergencies, the indignities of caregiving, they drained me dry. Even though I was lucky, he kept his sense of humor, his loving gratitude, and his personality. But still, you do everything and more while slowly losing your life, your love, and yourself. Now, 2 years later, dread and panic still overtake me. And the system of care made it harder. We can do better. We can make the integrated palliative care model available for all people with neurological illness. We can see the person with the disease and their carer as human beings doing their best to live a good life and help them do that. We can see they have more expertise than the clinicians with their individual experience. And we can join in witnessing how hard and how sacred the journey is, regardless of the disease.
My name is Kirk Hall. Please excuse me for reading my presentation today. I'm representing Parkinson's. I live in Denver, Colorado with my care partner and wife of 52 years, Linda. I was diagnosed with PD 13 years ago in 2008 at University of Colorado Hospital. My first movement disorder specialist transferred me to a new MDS on staff due to his specialization in cognitive issues, which were my primary symptom, Dr. Benzie Kluger. He used the Montreal Cognitive Assessment to determine that I had mild cognitive impairment in 2011. I was told that my PD had evolved from essential tremor, which was diagnosed in 1991. It now appears that my PD diagnosis may be a form of advanced essential tremor that includes a variety of Parkinsonian motor and non-motor symptoms. However, a recent DAT scan confirmed mild PD. The uncertainty of this diagnosis and its implications for progression are a major concern for me and up to 20% of ET patients. In the years that followed, my faith led me to become a PD advocate, writer, researcher, and speaker. These developments have been personally rewarding beyond anything I could have hoped for. I have often said that it feels like everything I did in my life before PD was preparing me for my life with PD. My advocacy experience has included giving patient perspective educational presentations to support groups, media interviews, participation in the 2013 Montreal and 2016 Portland World Parkinson Congresses, and my favorite, sessions Linda and I had with fellow PWPs and care partners, getting to know them, as well as providing information and answering questions about life with PD. In 2011, Linda and I attended a Parkinson's Disease Foundation Learning Institute in California. That was the beginning of a relationship with PDF, and a few years later, Parkinson Foundation, that has played a major role in my advocacy journey. It was a Parkinson Advocate in Research Group National Call with the Patient-Centered Outcome Research Institute in early 2014 that gave me the opportunity to ask if they would have interest in a grant proposal to fund PD palliative care research, and they said yes. The rest is history, with the best yet to come. Rome wasn't built in a day, and that was true as it relates to my relationship with Dr. Kluger. I don't think either one of us went into it expecting anything other than a normal doctor-patient relationship. However, what did develop far exceeded anything I could have imagined. Along the way, we discovered a shared interest for increased emphasis on what I would call personalized as opposed to industrialized medicine. This evolved into our shared journey thanks to his outstanding vision and leadership with palliative care. At the heart of the concept of palliative care is the need for a personal relationship with both patients and care partners. As I described with regard to my relationship with Dr. Kluger, this takes time. It seems to me that long-term relationships between doctors and patients are rare for a variety of reasons that will be difficult to change. My suggestion is to introduce palliative care as an adjunct service starting at diagnosis. This assumes that the palliative care team will be relatively stable in order to develop long-term relationships. For example, each patient and care partner should be introduced to the palliative care team and familiarized with their different roles and encouraged to meet with them when the need arises. This will reinforce the idea that palliative care is not just for those getting ready to die. This would set the stage for a transition to the activities currently envisioned for the palliative care team around mid-stage. By doing this, the hope would be that it would lead to planning activities sooner. This approach would demonstrate a commitment to maximizing patients and care partners' quality of life throughout their PD journey and reinforce that they will not be alone. A book I read recently titled Being Mortal provided a perspective that helped me reframe my thinking regarding the role of neuropalliative care for patients and care partners. Let's call them the patient team throughout the end-of-life process. Ideally, neuropalliative care will help the patient team to anticipate and plan for needs and wants that are important to them at each end-of-life stage. I would recommend that the palliative care team facilitate an intentional process, the result of which would be creation of a customized plan based on the patient team's decisions that will give them peace of mind. The patient team will then be able to communicate their wishes to family members to avoid future conflict or misunderstandings. In the end, the objective is for their experience to be as regret-free as possible. There is nothing else that I know of that has more potential to improve quality of life for people with neurological issues and their families than palliative care. Thank you for your efforts to make their lives and my life better.
Hi, my name is Michelle Moon. I am going to be talking today about my daughter, Juliana. She had CMT or Charcot-Marie-Tooth disease, which is a hereditary neuropathy. She had a severe type and died at age 5, about 5 years ago. In addition to being her mom and former caregiver, I am also a neurologist and now a palliative care doctor. So I'm going to be sharing from all of these perspectives. I'm going to focus my talk today specifically about pediatric palliative care, what makes it different and why it's so important. So I'm an adult neurologist, but I rotated through 3 months of pediatrics. It's a requirement for all of us. And I remember those months being the toughest of my entire residency, really for a lot of reasons, but probably the biggest one is that there's just something different when it comes to serious illness when it affects a child. We as neurologists see lots of bad, incurable, even tragic disease. But when a child has it, it just feels completely different. It feels wrong. And that's my first point I want to make about pediatrics. Kids aren't supposed to get that sick, and they're certainly not supposed to die before their parents. So living with this knowledge or the fear of this, it just brings an extra dimension of suffering that cannot be addressed if we as caregivers or care practitioners focus just on the disease. So the thing I remember most about the peds rotations is the parents. They had haunted looks on their faces. They just looked utterly exhausted. I remember feeling uncomfortable and pretty helpless just in the presence of so much suffering. So we focused on things that you're trained to focus on, like medications and diagnostics and new treatments. What parents really need sometimes, and what I certainly needed but didn't get until much later on, is someone who's not afraid to sit with you in that place of suffering. You really need a whole team to address all of that, all of it, and that's really what this is really what palliative care can do. Another thing that I think that makes pediatric palliative care more challenging is scarcity of everything. So there's a lot more rare disease in kids, and this means that there's probably not going to be a big advocacy group like the MS Society or the Alzheimer's Foundation. So parents have to work harder to find peers, and it's so important to find peers, people who know what you're going through. It means that there's less knowledge in the medical community at large, so parents have to be even more knowledgeable. They are not only the experts in their children, but also of the diseases. There's also scarcity of resources. For example, even if you manage to qualify for services, sometimes it's really hard to find a nurse who is comfortable working with kids. Pediatric hospice is another example. There are many areas in the country where there really is no hospice for kids. And the thought of families who are facing end of life in their child who cannot get that support is truly, truly heartbreaking. The last difference I want to point out is that the old adage is true. Kids are not just small adults, they're special. So Juliana, despite all the hospitalizations and the medical equipment, despite the fact that she couldn't even scratch her nose without help, didn't feel sorry for herself. Her disease was her disease, but she was still herself, and that was the most important thing. Once we, with the help of our palliative care team, started to focus on her, We followed her lead, and that meant a lot more playing, a lot more imagination, a lot more magic. It meant a longer and a better life. Other parents of kids with serious illness I've spoken with say very similar things about their kids. They're resilient, profound, joyful, in a way that we adults really can't understand. But if you are lucky enough to witness it, it's really humbling. There's a quote I love from a book called Harnessing Grief. It's written by a mom whose daughter has metachromic leukodystrophy. In it, she quotes a chaplain who says, "If you have the courage to be with these kids, they will teach you the very meaning of life." Thank you.
My name is Charles White, University of Rochester's Community Liaison. I want to share my experience with health disparities, racism, and biases in the healthcare profession. 4 years ago, I was diagnosed with multiple sclerosis, MS. From that moment on, my life changed. The trajectory of my life, hopes, and dreams were altered. I had no knowledge of the healthcare system, nor did I understand my diagnosis. After 1 week in the hospital, I was sent home. I was unemployed, alone, and suffering from the complications of the illness and trying to manage appointments and medication. I became very vexed in my spirit. I became homeless and alone, subject to the roller coaster of emotions. I am now faced with the high cost of healthcare and the biases of healthcare professionals. With no insurance, I could not make any appointments with doctors, nor could I get timely access to competent services and medication. For months, I lived in motels. I was back and forth to the emergency room. There I found healthcare professionals judgmental and acting on stereotypes. For example, doctors thought I was walking funny because of drugs or alcohol. MS can be a very painful medical condition. The emergency room staff not only did not treat my pain, but they treated me like I was trying to play them to get pain meds. I remember waiting in the emergency room for a whole shift with a barf bag and a sandwich. They did not try to make any diagnosis or help me. They couldn't get rid of me fast enough. Fact is, there was nothing in my history to suggest that I was seeking pain meds for any other reason than pain. I learned this is how biases and distrust affect the doctor-patient relationship, when there should have been a more person-centered care approach. I needed information not just about my health, but about the resources available to me so that I can get ongoing treatment. I did not qualify for social services or health insurance because of the amount my disability went over the amount that qualified me for insurance. People who don't have health insurance don't trust the healthcare system enough to make serious efforts concerning their health. In fact, they may self-medicate. Drugs and alcohol are often used for mental health issues, for the inability to cope with crises or illnesses, for emotional instability, or the lack of social support. Daniel proves reality is a spotlight on systemic racism, a structure and ideology that oppresses and limits resources to minority groups. The way healthcare professionals approach those who are historically marginalized and disenfranchised made me feel alone, naked, and afraid. I could not see a positive way forward. Is it possible that with early treatment, resources, medication, and a person-centered care approach from healthcare professionals could have improved my health outcome? Absolutely, yes. For example, before my diagnosis, I lived in an apartment complex with stairs. I had no wheelchair, nor could I climb the stairs. I could not leave the apartment complex for weeks. A physical therapist came to assess me, took notice of my living situation, and acted. She asked questions and, based on the answers, acted to help relieve some immediate stresses. She did my laundry and made an appointment for me with a wheelchair company. Now I have clean clothes, a new wheelchair. I make all appointments and I've started receiving my disability payments. After months without medication, I received a call from an insurance specialist from Anthony Jordan, asking why I haven't been making any appointments. I explained to her that I did not have insurance because my disability income disqualified me from insurance. She acted. She scheduled an appointment with me, did a financial assessment, and determined that I qualified for a program that gave me access to insurance. The actions by the physical therapist and insurance specialist are examples of person-centered care, ways to assess beyond diagnosis. These healthcare professionals did more for me than any doctor at this point in my life. I felt alone, afraid, hopeless, and with no advocate and with nowhere to turn for help. The actions by the physical therapist and insurance specialist gave me hope and a chance to regain self-worth and dignity, and allowed me to rise out of the depression and the self-pity from being newly diagnosed. These acts of kindness were from white women to a Black male. So it's not a Black or white issue. It's a willingness to change the way we see non-white patients. Healthcare professionals need to provide training to increase cultural awareness about the biases that exist, which could eliminate barriers and distrust from the community. Minority populations are underrepresented in healthcare professions. Healthcare providers should actively recruit and retain minority staff in prominent positions with a mentorship program assuring a successful involvement for the improvements of a more diversified, integrated, anti-racist, culturally competent atmosphere. For example, I have an African-American neurologist and a primary doctor. When I go to these appointments, there is an atmosphere of understanding and genuine care. I am more able to express my concerns about my health with the expectation that they will actively seek to achieve the desired health outcomes. In appointments with non-African American doctors, I am not as open, nor do I express all my concerns. That's because there is an atmosphere of distrust and a lack of concern about my health in general. Minorities and underrepresented communities have to be present and equally established in the healthcare system at all levels to achieve the common goal. That goal, first off, should be to provide quality healthcare to all, regardless of race, social status, financial status, or any other barrier that prevents any minority group from access to competent healthcare. The goal next is to address the lack of social support and racism that perpetuates negative health outcomes. Third is the necessity to adopt a person-centered care approach and culture across all care. That includes designing educational programs, as well as health promotions and prevention programs for patients. In doing so, we understand the importance of truthful communication and respectful, compassionate care. Medicine fails to address these issues, and thus institutional racism persists, and minorities suffer the full effect with no support and no true inclusion, no matter what status we achieve. This is bad and irresponsible medicine. Health professionals should actively seek to serve and heal, especially those who suffer disproportionately. I realize the importance of missionary work in bringing healthcare around the world, but charity begins at home, then spreads abroad. I am hopeful that those who have conviction and compassion will be a catalyst for the change that is so necessary, not only in our healthcare system, but in our own personal lives. Research shows that health outcomes for Black patients are better when they are treated by Black doctors. This is critical because African Americans in the United States experience poor health outcomes in a variety of diseases and conditions. Black men have the lowest life expectancy of any major demographic group. Doctors who understand the lack of social support and racism perpetuates negative health outcomes, then adapt a person-centered care approach, then understand the importance of truthful communication with respectful, compassionate care, address their own biases, treat people the way they want to be treated, see themselves in the patient, understand the physical, cultural, and mental health needs of African Americans and underrepresented communities are those who are culturally competent. Cultural competence is defined as an individual's demonstrated ability to interact and communicate effectively, respectfully, and empathetically with people whose cultural identities and backgrounds may differ from their own. Without it, clinicians risk alienating or even harming their patients. Don't be afraid to speak out against racism and racist action, and maybe hold monthly meetings to inspire and encourage team members. I don't think it's just a Black or white issue, but a willingness and a courage to change the way healthcare negatively affects the African American and underrepresented communities. And I think this can be a start in the right direction. Thank you for your time.
Hi, my name is Kelly Weinschreider. I was diagnosed with Parkinson's in 2002 at the age of 29. I currently live in Chicago with my husband, David, and our golden retriever, Archer. Thank you for giving me the opportunity to share my Parkinson's journey. The first symptom of Parkinson's that I noticed was a tremor in my right hand. In hindsight, there was a lot of symptoms that I had been living with that were indicative of Parkinson's: fatigue, foot drop, and stiffness on my right side. My arms no longer swung when I walked. These symptoms had come on so slowly that neither I nor my family even noticed. I saw my general practitioner, who diagnosed carpal tunnel disease and prescribed a rib brace. When the tremor moved to my right leg, my sister, who worked on a hospital neurosurgery floor, made an appointment for me to see their neurologist. After failing much of the neurological exam, the doctor recommended that I see a movement disorder specialist, where I received my diagnosis. That was in 2002. I worked for the first 10 years after my diagnosis. After starting medications, my symptoms were very well controlled. I did not feel the need to tell anyone except my immediate family. I kept most of the things that were changing with my body and my mind to myself. It seemed easier to hide the disease and get on with my life. I told very few people at work, not because I was afraid, but because I didn't want pity. As symptoms progressed, it became harder and harder to hide. My symptoms were a mix of motor and non-motor issues. In addition to tremor, my handwriting had become increasingly illegible. It was difficult to follow up on meeting items because I could not read my own notes. My cognitive multitasking and attention span and focus were declining, and the stress of my job amplified my symptoms. Anxiety became crippling. In my mind, everything was a crisis. Lack of sleep made my judgment poor, and medication side effects also contributed to my mental decline. I had been taking a dopamine agonist for 7 years and didn't realize the slow change in my personality and how obsessive compulsive I had become. My family knew something was wrong, but didn't realize the cause, and I was not self-aware enough to bring the options to my doctor. In April of 2011, I had a nervous breakdown and had to be hospitalized. After leaving the hospital, I was admitted to an inpatient adult day program for mental illness. I spent 4 months in the program working on my issues and thankfully gained an understanding of the benefit of group therapy. That's why in 2011, I started a young onset support group. It helped me to find friends who understood my Parkinson's journey and to find a piece of my identity, my new identity, helping others to live better with Parkinson's disease. In hindsight, if I could give a piece of identity to my 30-something self, it would be to find a therapist, a support group, a community who understands from day one. Throughout this time, I was on long-term disability from work. After discussions with my family and doctors, we decided that returning to my job was detrimental to my overall health, and the best course of action was to medically retire. Leaving work was extremely difficult for me. It was such a large piece of my identity. Meanwhile, my friends continued on with their normal routines while I had to rethink life at 39. 2012 was the hardest year that I've had with Parkinson's. Working with my doctor, I stopped taking a dopamine agonist, which was necessary to relieve my extreme mental health issues. In return, I declined physically, very rapidly. It took months to reverse the decline along with many medication adjustments and a lot of physical therapy. 2016, however, was a much brighter year. In February, I started a young onset group, and I'm proud to say that both support groups are still actively supporting people of all ages. In April, I had deep brain stimulation. By year's end, my tremors were gone. And for the first time in a long time, I felt really normal. This quote that I'm about to share with you means a lot to me. And as I age, it becomes more and more relevant. It was written in a blog by Cheryl Jedlinski and Jane Burns on their website, PD Plan for Life. It seems a lifetime ago when I arrived on the Parkinson's scene, fearful of what the future held for me, and hungry for whatever knowledge, coping strategies, and experience others with Parkinson's were willing to share. At some point when I wasn't looking, I became the old timer myself, teaching newbies, as others had taught me, to face this progressive disease that has no known cure with courage and grace, giving them the confidence to try new things as well as old things and in different ways. They go on to talk about their friends, relatives, doctors, and therapists, that they're village people who would help them to live well with Parkinson's disease for so many years. Being a person with young onset Parkinson's, I didn't know I needed a village, and building my own was very difficult. I often found myself in the middle of my general practitioner, movement disorder doctor, and my own I'm a doctor mindset as to whether something was or was not Parkinson's related. When I had issues that were out of the scope of traditional Parkinson's, I had to seek my own specialists. One night in the ER, I was called a medical hot potato by doctors from all different specialties. My dad had Parkinson's, and my mom and I, along with his doctor, were his village people. Being a person with PD for so long, I understood a lot about living with the disease day to day. I helped my dad with his overall care, but was surprised to realize how much my mom and dad would have struggled and my dad's care impaired without my help. He had dementia, so understanding what was happening to his body and the ability to communicate that to a doctor was lost on him. He would have lived with a lot of side effects and untreated symptoms had we not been by his side. His inability to effectively manage medications and worsening symptoms led us to put him in a memory care facility. He passed away in July of this year due to complications of the disease. The last 20 years have not been without challenges, but it's also been very rewarding, and I've accomplished a lot despite PD. I have 5 patents, I married a wonderful man, I traveled the world, started 2 support groups, and helped my dad when he needed me the most. Over the years, I've learned 2 very valuable lessons. 1, keep a positive outlook, and 2, how to advocate for myself and others. Don't just accept life with Parkinson's. It takes time and effort to find a strong support system, both medically and personally, or your village. In closing, I would like to quote Davis Finney, Olympic bronze medalist and founder of the Davis Finney Foundation. We can't control that we have Parkinson's, but we can control how we choose to live with it. Thank you for your time.
Hello, my name is Malenna Sumrall. My journey as a care partner was similar to that of others in many ways. My husband, Ray, was diagnosed with Parkinson's in the year 2000. 9 years later, dementia was added to his diagnosis. His medical care ranged from inadequate to superb, from a neurologist who had little knowledge of Parkinson's to the ultimate experience of having palliative care as part of his treatment. I could recount the problems that we had along the way, but you have heard these tales before. Today, I want to talk to you about an ever-growing need that care partners have. My experience with neuropalliative care made me a fierce advocate for the treatment model itself and for care partners who face difficult circumstances. For the past 5 years, in an effort to provide additional support, I have worked with care partners in a variety of ways. As a clinic volunteer, as a support group leader, and as a vocal advocate. The life of a care partner is filled with uncertainties. There are daily, sometimes even minute-to-minute challenges, including the grief, the guilt, and the fatigue that we all experience. And no matter what we read, we find ourselves feeling unprepared to handle the complexities of caring. Care partners try their best and want so much to help their loved ones. However, few can say that they are prepared intellectually, emotionally, and physically for dealing with the symptoms of the progressive disease they face. We try to use our best judgment in new and difficult situations, but we aren't always successful. We are desperate for strategies that are practical, sound, and research-based. Good luck finding these strategies on the internet in a concise format. What I would like to propose are disease-specific guides for care partners that would, for each potential symptom, provide 4 things: strategies for helping them and their loved ones manage those symptoms; 2, suggestions about how to prepare our lives, our homes, and ourselves for these symptoms; 3, suggestions for finding joy and meaning in the midst of the symptoms; and 4, strategies that help care partners cope with their own feelings when the symptoms arise. Being able to better manage our journeys has multiple benefits. First of all, the problem raised by the symptom can be eased. Second, the fear and anxiety that the loved one experiences because of the symptom can also be eased. Third, the overall experience can be richer for both patient and care partner. And finally, the care partner can feel that he or she has had a small success, something we rarely feel, and that helps reduce the burden of caring. In palliative care, we hear about a roadmap that can help anticipate the progress of a disease. Perhaps a complementary version, a roadmap for care partners, could include the advice we need. Or maybe there could be smart phrases in EPIC that could be used in after-visit summaries. There could be websites, printed guides available for free. Any or all of these options would be welcome. We just needed it yesterday. I often tell people that caring for my husband was the hardest thing I've ever done, but it was also the most loving thing I've ever done. Although I hate that he had to go through his illness, I'm grateful that I could be the person who cared for him. That being said, I would have been just as grateful if my job had been a wee bit easier. The fact that INPCS includes patients and families along with all sorts of professions related to care is huge. It says to me that you want to know what we think and what we need. I hope you will continue to hear our voices as the society grows. I am thrilled to see INPCS getting off the ground and look forward to the progress I know it will make.